My name is Asaf Kedar. I'm the head of the trauma unit at Hadassah University Hospital in Jerusalem, Israel. Today I would like to speak to you about mass casualty incidents and to share some of our experience from the past years in Jerusalem, Israel. This lecture is not intended to be a full lecture and a full instruction course about mass casualty, just to share with you some of the highlights and the most important issues that we need to be prepared for. Preparedness. I think that is the most important thing when we come to speak about mass casualty event. We need to be prepared. We need to be organized. And the organization is not only in the medical field or the surgical field. It's the entire hospital and everything that is related to the hospital's administration, different departments. On top of that, we need to have some mental preparation. We're going to face some horrible images, very difficult situations, and most importantly, very difficult decisions. It's not mass casualty event is not like conventional medicine that we're treating. We'll have to face very difficult decision-making points. We need to think about preparedness in the scene. This is mainly responsibility of the emergency services, the ambulance services, and in the hospital. And those two things are a bit separate. I'll focus my short talk regarding the hospital preparation. And the most important thing, have a plan. Be prepared. A few concepts that we need to keep in mind when we're talking about mass casualty events. Multiple casualty incident is something that a lot of hospitals experience. It means that there was a car accident with a few casualties. It depends on the size of the hospital, the effect of these casualties on the hospital. Usually 2, 3, 4, even 5. It's a burden to any hospital, but it doesn't stop or change the regular activities of the hospital. On the other hand, a mass casualty event is an event that changes and affects the entire hospital work. Okay? Everything needs to stop. Everything needs to be focused on managing this event. It's important to differentiate between the situation. The treatment that we give in mass casualty incidents is the greatest good for the greatest number of victims. And this is indifferent to our regular life, to our conventional medicine, that we do the best that we can for the individual patient. And at that point, we need to take some very difficult decisions. Some of the principles of preparation: emergency department setup, organizing clear chain of commands, in-hospital triage considerations, personnel and resources recruitment, and drills. I'll go point by point. First, emergency department setup. It has to be tailored to the hospital. Not all hospitals are the same. The structure, the physical structure is different, the personnel that is available is different, the terrain is different, and we have to tailor it to the hospital. Also, different hospitals have different departments, different managing ways, and we need to tailor the program and the preparation to our hospital. Triage. The triage is very important. It needs to be located outside the building in an open space because it's a bottleneck. And we don't want this bottleneck to be inside the building, it needs to be outside. And we need to have somebody that has an experience and knowledge in triage. I'm not going to focus how we do it. There is plenty of literature and it's important to read and to know the literature regarding triage. It's very important that in the preparation and the setup we'll have a one-way direction of the patient. It goes into the emergency room and from there, wherever we need, imaging, CT, ICU, OR, but it doesn't go back and forward. It doesn't go to the CT and back to the emergency room. It doesn't go to some imaging and back. No, it's a one-way direction. Organize and clear chain of command. It's a very hectic situation and we can't have 10 different people giving orders to the same person. There needs to be a chain of command. The correct person that needs to take decision needs to be in the right place. For instance, we need to decide who goes first to a CT scan because not everybody can go in the same time. Not everybody can go in the same time to the operating room. We need somebody to take decisions. And we need involvement of all hospital departments. Okay? We need security to manage the crowd. We need the press people to manage the press and the information to the public. We need people from supplies to move things from the storage and bring for us, and so on and so on. It's not only the medical and nursing staff. It's all the departments in the hospital. In hospital triage, the patient goes into the emergency room and is being set in a certain point, either in immediate or delayed or minimal and so on. But sometimes we start treating a patient and then we find out that he's more severely injured than what we originally think. So we need to move it. So in-hospital triage is also very important, so the patients will be in the correct place that will get the best treatment. Personnel and resources recruitment. Managing the human resources is extremely important. We need to think about now how to manage the event, but we also need to think about the following day regarding who is doing the morning rounds, who is continuing treatment later on, who will do the surgeries that we don't need urgently now that we'll need tomorrow. Also, we need to manage that we'll have the right people available, people to move stretchers, people to bring food to everybody and water, and so on. Maximum utilization of hospital facilities. Okay? We need to see how we can most efficiently use everything that is available. For example, during the day, most of our operating theaters will be busy. We need to see how we can move as much as possible so we'll be available to the wounded. Use simple and available techniques. There will be some bottlenecks during the treatment in a mass casualty event. And sometimes we can use something that is very simple in a very good way. For example, an ultrasound machine. Today in the ultrasound we can evaluate the abdominal cavity and the thoracic cavity quite well. We can utilize the ultrasound more and maybe avoid doing a CT scan, at least initially, and we can postpone to CT to a later point. X-ray that we can use, simple labs and simple procedures. And the last thing is to drill. We need to make a plan and we need to drill it, have some conclusions, some debriefing, adjust the plan. And again, and drill, and drill, and drill, and once we drilled enough, to drill some more. And it's not enough to do it only now, we need to do it in a few months, and the year later, and the year later, because we have new people that need to be trained. And we need to adjust the plan according to how the hospital is changing. So it's an ongoing work that is never finishing. Now my colleague Dr. Beyth will continue to give you some of his experience.
I'm Shaul Beyth from the orthopedic complex in Hadassah Medical Center, Jerusalem. Together with Asaf Kedar, my colleague, we are sharing today with you our experience, and I would like to continue from the place where Asaf stopped, which is drilling. And the reason for keeping on drilling is because once a mass casualty event starts, there's nothing you can do other than do whatever you have practiced before. Since mass casualty event or incident by definition exceeds the capacity and the potential of treatment in the hospital and takes all the resources of the hospital into this event, then by definition the quality of care decreases and everyone is engaged, and whatever you haven't practiced before will not be done. I would like to take you into this event. Hopefully you will never have to mitigate it, and let you know what you can expect. What is the scenario that you will face once this starts, and draw some conclusions and some insights. The first and most important one is that as opposed to treating a patient, any patient, that is usually, hopefully, a successful treatment, even for a severely traumatized patient, a mass casualty event is an experience of a non-success, since we cannot deliver our best quality treatment to all patients. We will be left at the end of this event with the feeling of missing, that we could have probably, in another scenario, treat some of the patients in a better way and reach better results. This is one of the reasons you have to prepare your team. You have to support your team before you have to acknowledge their efforts. You have to let them know what it will be feeling afterwards. You have to drill and simulate And in our years of experience of mass casualty events in Jerusalem, we evident all these feelings. Some of the things you can expect is the collapse or at least difficulties in communication. The cellular network and the computer broadline or broadband may collapse, and you will have to go back to the Middle Ages or to the Stone Ages, writing on papers, transferring information by landlines, and have difficulties. In addition, imagine that you cannot use your cell phone, not for taking pictures and transferring them for consultation to your colleagues or your supervisors. Imagine that you have no option of reaching people that you are always available to or that are available to you, for consultation, and you're left alone with the position you're at. Add to this the possibility that your hospital is sort of isolated because the cellular network is down because everyone is using it. At this point, you don't really know what is coming next. You don't really know where your family is. You don't really know if you can expect some relief in the near future. All these are sources of stress to the team. You can expect problem with medical documentation because patients are coming in, not always identifiable. They don't always come speaking your language, not always able to speak. You have to attach a medical chart to each patient, but for identification you have to form charts in advance with numbers to identify the patients. Only at a later stage will you be able to change the numbers into names and into medical background. You have to be prepared to create a designated information center in the hospital to let other people know who your patients are so that they will stop looking for them, so that caregivers in the hospital will be able to identify their patients and not have duplications. You will have bottlenecks. We all have bottlenecks in our hospitals. Sometimes they are not felt during the ordinary days, but once you're trying to move back and forth with an influx of patients coming in, then you start having problems and traffic jams. You would like to have a way pre-planned for all patients from the hospital entrance to the floor bed through all facilities that they need, may it be the trauma unit, the emergency department, imaging facilities, operating theater, ICU, and so on. You have to take the floor plan. You have to think about which way is the one way, including the one way of the ambulance teams taking the stretchers out back to the ambulances, including a one-way traffic of ambulances inside the campus, and avoid bottlenecks. Marking the floor may be the best way to guide people outside of the hospital through the corridors. You should expect personnel shortage since this is the definition of a mass casualty event. There is shortage. And when there is shortage, the ability to deliver high quality care diminishes over the extent and the load of patients. The more patients you have per hour, the less ability you have to deliver high quality care. And if you recruit more patients, you can shift the sigmoidal graph a little to the right and be able to deliver a high quality or above 90% to more patients. Therefore, you should have a designated plan, as mentioned by Asaf, that once a mass casualty is declared, you should call in and recruit as many people as you can, at least for the first stages. You should be prepared to the fact that sometimes you will have news or indications of an imminent mass casualty event. You will recruit everyone into the hospital and then dismiss them because nothing happened. There was a not true event or smaller than you thought. Nevertheless, you have to drill it, and recruiting all personnel is probably one of the best drills you can have. personnel you're bringing in may be worried about their family members and unable to connect with them. In this case, you will have problems recruiting and maintaining the personnel in the hospital. Regarding personnel, you also need to define the hospital capabilities in order to know in advance when to declare a mass casualty event and start recruiting. To define the capabilities of the hospital, we can offer you some of our experience in Jerusalem from a suicide bombing took place in the center of Jerusalem some 21 years ago. We know that all patients entering the hospital at a trauma setting need to see a general surgeon to overlook the trauma care. Many of them, at least in that event of a blast injury, needed an ENT doctor. Many of them need plastic surgeons, orthopedic surgeons, neurosurgeons, and so on. Most of them needed, all of them needed some imaging, from plain x-rays to abdominal ultrasound and to more complicated exams. It is easy to calculate how many of these precious positions you have in the hospital and how many of them you will be able to recruit in a short time. In addition, once you have an action flowchart formulated, look at the key points of preparing the first OR immediately, preparing the first ICU bed within an hour, and expectations to how many of your patients will need surgery and ICU beds. Based on our knowledge and experience, 1 in every 8 patients will need surgery. 1 in every 8 patients evacuated into the hospital will need an ICU bed. If you are expecting some 40 patients and you have less than 5 free ICU beds, you're in the mass casualty event. Last but not least, drill and drill again. This is different than anything we all know from our daily lives. It's a different event, and hopefully you will never need to practice. Thank you.